Thank you very much for having the opportunity to come and speak to you today, and good morning to the whole audience. I want to share with you what we're doing at Mayo Clinic in terms of transforming our model of care, which Tom just pointed out is voted as the #1 care delivery model in the United States, and how do we incorporate the modern technology tools we have. And in order to tell that story, we need to take a little bit of a trip back in history to understand what Mayo Clinic is, and how that became the #1 healthcare institution. So Mayo Clinic exists in its primary location in Minnesota, which, if you're not familiar with the geography, is in the middle of the United States on the northern border, so a very cold area. And the city that Rochester is only about 100,000 people big, so it's a very small city, not near an urban center. So why is it there? It's actually there because of a natural disaster. A tornado came and wiped out a small farming community there. It also happened to be the location of a convent. And the nuns who were trying to take care of the sick and dying and wounded recruited William Worrell Mayo to come help them take care of these injured individuals. And once they had recovered from that natural disaster, they then recruited him to start a hospital in Rochester. So the origins of Mayo Clinic, now about 155 years old roughly, stem from a natural disaster from the nuns of Assisi Heights recruiting William Worrell Mayo. He then sent his sons, the famous Mayo brothers, William and Charles Mayo, to medical school, and they founded what became Mayo Clinic. And what's on the slide here is a quote from William Mayo that is the basis for the Mayo Clinic primary value, and that is the needs of the patient come first. Not the needs of the hospital, not the needs of the doctor, but the needs of the patient. And we have always kept that at the center of what we're doing. So they started to develop care models. The Mayo brothers are both surgeons. They recruited a genius of a medical doctor, Dr. Henry Plummer, to help them with the medical side, and he also designed the healthcare clinic and a paper medical record that is actually the basis that most EMRs based their philosophy on, and that is an single integrated record across both inpatient and outpatient care. And the model of care also let physicians specialize. They didn't want doctors to be jacks of all trades, everyone doing everything. They wanted to have individual foci so that they could push the boundaries on care in one area, but they required that everyone work together. So if they were taking care of someone with thyroid disease who also had a stomach issue, the ability for a patient to get care for most of those issues could all be accomplished in one day. So the beauty of Mayo Clinic is that patients can come and get multiple systems analyzed and treated all within the course of about 2 or 3 days during a trip to Mayo Clinic. And so that is the integrated multi-special model. You can see we now employ about 4,500 physicians, and we treat about 1 million to 1.5 million patients a year from all over the world. More than half of our patients travel more than 100 kilometers to come to our facility to see us. In fact, many come more than 1,000 kilometers to come and see us. So that's a little bit unique, and that's the context of the Mayo Clinic model of care. Again, I mentioned this team approach. It's focusing on the patient as a whole individual. We don't treat diseases. We treat human beings who happen to have diseases or health conditions and try to make sure all their health care needs are met. We have a unique system where we have a very relaxed schedule compared to most physicians. We have the time to sit with a patient and hear their whole story, to make sure all their questions are answered, and then we make sure we communicate with them and their primary care provider to continue their care when they leave. So this model is a cooperative science. It's teams of specialties, and it's taking care of a whole human being, not just the diseases the patient presents. So that's the history of Mayo Clinic. So how do we transform that into the modern era? Remember, the Mayo brothers started the Mayo Clinic at a time when the only way you could communicate with a doctor was to be in the same presence as the doctor. In that era, it probably meant getting on a horse or in a horse-drawn buggy to get to where they were in order to get that done. Well, we don't need horses and buggies anymore to communicate with our healthcare team. So how do we put the patient at the center? The graphic up here on the right is supposed to be representation of a human being's life. They spend far less of their life in the clinics and more of their life being human beings, working, going to school, being with their families. But we've always forced healthcare to occur. Patients have to stop their life to come and see me as a doctor, and then they go back to their life once we're done with our care. We transform that model into the figure in the upper left there, keeping the human being at the center, keeping them engaged and learning about their own health to empower them to take care of themselves with us. And then there's different phases. There are times when patients are learning about their disease and we're helping them understand whether that care needs to be escalated. Do they need to contact a provider of some sort? Do they need to come to a clinic for testing? Once they enter a phase of management where they are getting treatment for a disease state, we help heal them, we help monitor them during that phase, and then we transition them back to their healthy life otherwise. And that's the 360-degree view of a patient journey that we try to focus on for each of our patients. This is predicated on the things that we're seeing in every other industry of our lives. Healthcare is lagging everyone in this regards. You think about how every human being wants things that they're dealing with every day in the palm of their hand, in their smartphone. The banking industry transformed this years ago. You used to have to go to the bank to put money in and get money out. Now the banks in the United States don't even compete on whether they have an app for their bank. We all expect them to have an app that we can pay our bills, transfer money, make investments, even get loans online without going to the facility. The same for the travel industry. My parents used to have to go to a building to talk to an individual about the trip and vacation they wanted to plan. Now I guarantee someone today is going to plan their next vacation while they're sitting in the audience, all in the palm of their hand. And as we know, for better or for worse, people conduct entire relationships without being in the same location now. Start them, end them, whatever, all electronically. Human beings are going to demand that their health care be delivered in just as convenient a way as these other industries have done that. So this was the vision that the Center for the Connected Care at Mayo Clinic was created. At the time, there was about 60 projects on reaching out to patients where they were, either using video telemedicine or other tools. And Mayo Clinic created a business plan for this Center for Connected Care with the idea that this is everything we do to reach out and engage our patients without forcing them to come to our building unless they need to. Obviously, we're not keeping people out who need care, who need physical presence, who need someone to lay hands on them or to have complex testing. But if they don't need that, why should we make them stop their lives and travel so far for something that we could handle remotely and more conveniently for them? So the Center for Connected Care has its value statements there in the bullet points. The real idea is to right-size the complexity of the interaction for the need the patient has at the time. That will clearly benefit a patient who might have to travel so far to see us, but it also can help the institution. If we make the healthcare interaction fit the actual need and not force every round peg into a square hole, we will open up access more appropriately for patients who need it when they need it, and that should have overall financial bottom line benefits for our care. The graphic in the upper right of this slide is a reminder that we're not just a technology shop. We just don't bring digital tools and say, here, use this. We're more of a solution shop. We have teams of people who understand the digital products that are out there in the world. We have lawyers and compliance officers who understand in the climate of the United States what laws regulate our ability to do this, what reimbursement models exist that we can take advantage of. And we have business analysts that help each practice area understand what the value proposition is specifically for a cardiologist or a general surgeon or an obstetrician. And so we centralize many of these core knowledge functions within the Center for Connected Care while trying to keep the care delivery integrated into the practice. We don't necessarily want our neurology department to have an in-person neurology department and a digital neurology department. We want the doctors to be doing both when it makes sense for their patients. I stated to my bosses that I will consider myself successful in this job when people actually stop talking about connected care and they're just doing it without thinking about it as part of their everyday life. So continuing that integrated model of care delivery at Mayo Clinic as part of a daily life of a provider. This is another slide that expounds the benefits in terms of what do patients get. Again, unique to the Mayo Clinic compared to many of the regional hospitals here in the Netherlands, people are traveling a long distance to get our highly specialized tertiary and quaternary care, so we can save patients lots of logistic hassles. But we also have tools that just keeps them out of the hospital generally, or keeps them in the right hospital rather than always being transferred to the highest cost, highest end hospital. For Mayo Clinic, we talked about how that can be beneficial to the health system. But physicians, we all are very smart and stubborn individuals, and so they always ask, what's in it for me? Why should I use these extra tools in my practice? Well, the reality is most of the physicians are taking care of more patients than they have space for in their calendar. But that's because we're forcing low acuity patients into standard appointment slots. And if we can take care of a patient in a lower touch way, when it can be done appropriately in a lower touch way, we open up access for that physician. We also know that some of these digital and remote appointments take half the time as a face-to-face appointment does. And again, that gives physician more time on their calendar, either to see an additional patient if he or she chooses to, or to do some of the other clerical activities around healthcare that is really contributing to the burnout in physicians, et cetera. It gives them more space on their calendars. I mentioned this. This is just a listing of the types of jobs we have in the Center for Connected Care at Mayo Clinic. Our group is about 150 employees that work for Connected Care in various aspects of these roles. We design ourselves around products. What are we offering to the clinical areas? So when I took over Connected Care, we had those 60-some projects. Projects, by definition, have a start date and an end date, and then the team moves on to the next project. But the clinical practice said, well, we did that, we liked it, we want to keep it going, and we had no operational team to maintain the structure of that project. And so we actually also had lots of redundancies. We had a dozen different video telemedicine endpoint solutions in various aspects of practice at Mayo Clinic. That is not sustainable as an organization. It's redundant, it causes lots of technical debt for your organization. So we converted that project mentality to a product mentality. What is a scalable solution for the practice of Mayo Clinic? There isn't anything unique between a thoracic surgeon and a general surgeon in the video telemedicine needs they have. Let's get them all on one system. So we've now reduced that to 2 video systems, one for video solutions between other hospitals and one for video solutions between patients in their homes. And we've stood up what we call the run organization or the maintenance organization. When we implement a team, then there's a support structure to support their product going forward. We have about 100 ongoing implementations in our clinical practice at any one time. On the right-hand side is how we, within the infrastructure of our system, organize the operations to support those product lines. And the product lines we'll talk about in more detail are things that we do asynchronously. My team is responsible for the patient portal. We have our own user experience portal that goes on top of the EHR portal because we've won awards for our ability to engage patients and keep them interacting. We have the whole video telemedicine line that we'll talk about. And then the biggest one is the use of data, remote patient monitoring to make sure patients are okay. That's the new kid on the block and probably the one that's going to change the game the most down the road. This is a graphic that we borrowed from a consultancy firm that talks about the spectrum of care from ambulatory through acute care and down to post-acute care. All those in green are things that have been implemented at Mayo Clinic. All of those in Dutch orange are things that are on the roadmap to be coming in the near future. So we are very active across the journey of a patient and their healthcare needs. This is another way to look at that. When you talk about a patient who has a healthcare need, there's things that you can do to help a patient before they arrive at your institution. We call that pre-visit activities. Then we have the actual care delivery phase, and then the transition back to health phase. And we have solutions that will help make it more efficient for that patient, more engaging for that patient along that whole care continuum as well. So let's talk about some of the data that we have. This has to do with patient online services or our patient portal, which both has a web presence and an award-winning app. We have about 1.5 million account owners now, and 70% of our patients utilize the portal as part of their care episodes. In the United States, that's about twice the average for most academic medical centers, and we believe that's because of the user-centric design that we use in developing the portal and the interfaces. We were early adopters to letting patients see their own notes in real time. Most institutions, the finished physician notes are buried about 8 layers deep in their app. It's the number 2 utilized function on our app, is the patients wanting to see their notes. The number 1 thing they look at is their lab results. And often patients are coming into their doctor's office now and saying, how come my potassium level is wrong? Even before the doctor's, he's booting up his computer. I find that be very beneficial. The patient's engaged and they want to know, why is there a star next to that one? That allows us to have a dialogue about abnormal test results. On the left-hand side are all the basic features that we provide, and these are all things you would expect in a business model for digital healthcare delivery, with one glaring exception that we're working on, and that is the ability for the patient to schedule themselves. There are many primary care practices that are doing that. Mayo Clinic hasn't done that because of our highly specialized nature. We have pretty complex decision trees and algorithms to get patients to the right type of provider or the right specific provider, and we're working with a consultancy trying to use a machine learning or AI approach to automate those decision trees, to put them in the palm of a patient's hand so they can self-triage themselves. So that will be coming. This is just a slide to remind us that there is demonstrated value to doing some of these asynchronous or store and forward activities. It makes care more accessible to patients. It stops people from paying telephone tag. It saves dollars in the healthcare institution because many things can be done to make sure a patient is okay just by saying a few things back and forth to one another. We can deliver online questionnaires. We can do lots of things in this venue that have been proven across multiple countries to save the healthcare institutions and patients dollars and time. Video telemedicine is probably the sexiest thing that most people think of when you talk about remote healthcare delivery, and that's probably because it's the most familiar. It's just simply moving the office visit to the patient's home or to a facility closer to where they are. It's actually the most complex solution you can put in place because it requires scheduling, requires simultaneous presence, requires technology endpoints, and requires network bandwidth to make that work. So it's probably the most complex solution you can think of, which I think in the long term means it will be not the number 1 utilized thing. It will be used when appropriately, but right now it's the entry gateway to digital healthcare for most people. We divide our activities around 3 distinct domains. One of them we call Care Anyplace. This is for us to see patients in their homes or offices or hotels or wherever they may be in follow-up for care they've received at Mayo Clinic. Someone may have had an operation, and rather than make them travel 450 miles back to see us to tell them they're okay, we could do that in the comfort of their living room or their office and save them time and dollars. The second is doing specialty consultations to patient and primary care clinics. So Mayo Clinic owns about 50 small clinics in the surrounding 30 counties around our main campus. And we used to have a model where originally the patients would travel to the destination medical center to get their care, obviously very inconvenient for the patients. Then about 30 years ago, they developed a model where we sent the doctors out in their own cars to go visit these clinics, called that outreach. More convenient for the patients, took physicians out of the usual practice and reduced productivity to some degree, but physicians didn't mind. It gave them a little bit of time away from their pager and their phone, but they were seeing kind of bread and butter specialty care out in the clinics. But now we use video. So rather than send a cardiologist 50 miles to the road, I can do multiple video consults with that practice and see patients in my physical location in Rochester and do some of the business activities I'm required to do to be part of the Center for Connected Care. The next bullet on the slide is acute care video telemedicine. These are the high-end things like telestroke, where patients can having a stroke in a rural hospital normally would have been transferred by ambulance or helicopter to the major medical center. We now, by video, put a stroke neurologist in charge of that patient's care where they are. I have a slide coming up on some of the value and data we have around that. We also do that with neonatal medicine. Our emergency department now has video connections to most of the small emergency departments in our surrounding areas. Often, many of those are staffed by nurse practitioners or physician assistants and not physicians, and their usual mode is stabilize the patient and transfer them to the major medical center. Now we can have the physicians from our emergency department help care for those patients there and determine that many of them can actually stay where they're at and don't need to be transferred to our facility. And we're even extending that on the very last line to now putting video equipment in the ambulance services themselves. Portable video equipment. The original intent was that they could then start care during transfer, but because these devices are so portable, some of the paramedics are taking the equipment out of the ambulance into the home or into the field, so the physician actually starts to see the patient where the paramedics find them. And that, again, advances care, speeds time to delivery of important life-saving interventions. One of the things that you have to think about when you are engaging a practice, and I'll come to this in the end again, is if you come to them with tools and services, they think you're asking them to do something extra. And so we're starting to change that and ask them to tell us what problems they're trying to solve. And one of the things that we do is we have them work through this. If you're thinking about doing a follow-up visit for a patient, or a patient needs follow-up care, what's the best venue and the best channel for that follow-up to occur? Do they actually have to come back to Mayo Clinic for care, or is this something their primary care team can handle? If so, let's make that transition as smooth as possible. If they do need care by our specialists, do I need to see something? Do I need to see it move in real time? The answer to that question determines whether the patient might need to come back for me to touch something, a mass they have in their neck, for instance, or have a photograph of a skin lesion, or a video of someone who has a gait disturbance, and all I need is to see them walk across the floor, and we can then elevate their physical therapy they might need for that problem. And working through an algorithm like this can help providers see how they might give care more conveniently to the patient. Our video appointment at home is technology that patients download onto their own devices. It can be a computer, a tablet, a smartphone. Our team walks the patient through the downloading of that software, and when the time for the appointment comes, our team contacts the patient first, does all the technical troubleshooting that might be necessary, and then sends a message to the provider that the patient is now ready, so that when the doctor comes online with the patient and doctor aren't doing technology troubleshooting together. That's not what you want to happen at that phase. That's all taken care of to begin with. And then they conduct their video interview, and then the documentation is done the same way. This is one provider story. This is a surgeon, a thoracic surgeon at Mayo Clinic. So he took care of 263 patients in almost 30 states. You can see the average length of follow-up for these visits was 7 minutes. His in-person follow-up visits are 15 minutes. That's a unique aspect of a patient traveling as far as these do. When a patient comes 100, 200, 500 miles to see me, they have nothing else on their calendar that day. And we talked about how we value this unhurried examination, so the patient assumes and desires some time to just hang out and chat. Nothing wrong with that, but if they don't need to be in my office because I don't need high-end testing or I don't have to physically touch something, and the patient wants to do this as part of their usual business day as well, then it's just another appointment on their calendar as well, and the interaction becomes much more focused on the problem at hand. We're not trying to get rid of the humanistic aspect here, but we're trying to make it more convenient for patients. You can see that the average distance that this provider's patients travel was 1,000 miles. The patients in these 200 patients had 100% satisfaction. They all said, I would do that again if the need arises. And these are patients whose average age is in the upper 50s and low 60s, some who were 70 and above. So the notion that older patients won't do this is more myth than reality. Older physicians might be unwilling to do this, but the patients who have the biggest problem getting to healthcare organizations are those who have less mobility and more frailty. Well, guess who that is? That's our older patients. They're pretty tech savvy. They're very willing to do a video visit if you offer it the right way. And it was a question last night during the captain's dinner. The best way to introduce this is to have the physician introduce it. You can't have an office staff individual propose it to a patient. They feel like that is impersonal and they're being kind of put out to pasture in a way. But if I introduce it to a patient and say, look, I have a really convenient way for us to keep track of how you're doing, rather than having you come back to see me, why don't we just set up an appointment for 3 months from now and we'll do it by video? Patients like that. When it's introduced by their provider, by their team member, it becomes much more acceptable. I'm just going to go back to that slide. So the data isn't here, but so we also collected financial data on these patients, and we saved the patients on average about $850 per patient on out-of-pocket expenses using a video visit rather than having them come to Mayo Clinic because they have to get travel and lodging, et cetera, to come and see us when they're from so far away. So it saves the patient dollars as well. These are the data on the telestroke program. So the important thing is that in a model of about 8 hospitals, a central hub and 8 hospitals connected to that telestroke site, in 1 year we saved the healthcare system $1 million in stroke care. And it reduced loss of function for the patients having stroke and kept more patients alive, returned them home sooner. Because what we're doing here is delivering a drug that interrupts the stroke in a very narrow window where its efficacy is highest. And if we can do that care where they're at when they come in with the stroke, much more likely to hit that time window. A very effective program. Similarly, for babies born unexpectedly in distress, the model was to call the helicopter and send them to Rochester. Now we can have our neonatal intensive care specialist supervise the resuscitation at the birthing center, and in many times the baby never has to leave that hospital. They can stay there with their mother in the same hospital and not come to Rochester for that. So again, it saves babies, which is the most heart-tugging story there is. It saves unnecessary transfers, and it also can save healthcare costs across the system. Now, I'm going to switch gears. The video telemedicine and the portals are pretty mature products that we have and many hospital systems have. But this remote patient monitoring, the use of data collected from the patient, is going to be the biggest evolution in care delivery, in my opinion. Right now, we're in kind of version 1.0, where we have devices that bring the patient's blood pressure in or their weight in, or we have survey data that comes in, and we have physicians or nurses looking at dashboards and then reacting to patients who are falling off their expected trajectory. And that's great, and we'll talk what comes next. So we do this in something that's called complex care. We identify patients who are at high risk for getting admitted or readmitted to the hospital. These are likely patients who have heart failure or COPD, difficult to manage diabetes, et cetera. And by implementing them, giving tools that they take into their home, that we send a team out to get them set up, we can monitor how they're doing. And what we showed in a study of 400 patients in primary care practices at Mayo Clinic was that we reduced readmissions by 48% amongst those patients likely to be readmitted for the ones who had the devices in their homes in our care team. The care team to support this tool is we have our own set of connected care nurses that are the ones that monitor the patients, will contact them if they see deviations in what the data is showing, and then decide whether that care needs to be escalated to their provider or the patient simply needs more education about how to manage it themselves. It has been a very effective way to manage those patients. Again, this is the workflow we do. Patients are identified based on risk scores within the EHR. We tee it up for the physician in their we use Epic in their Epic ordering system, so the physician doesn't have to identify this. Our team identifies it and offers it as an order that all the physician has to do and endorse, and then our team takes over implementing the patient and getting them enrolled. As I mentioned, the patient gets taught about how to use the devices. We have our own monitoring team that serves as an intermediary between the patient and their standard care team, so that the standard care team isn't worried about technology failures or what all this data might mean. Our team helps interpret that for them. And then patients eventually graduate from our program. And right now we have about 600 patients monitored every day on this program that our team is monitoring. Again, these are just some quotes from the patients who have been part of this program, but the key statistic there is in bold on the top line. Of the patients enrolled, there's a 98% acceptance rate. Again, just another piece of evidence to show that while it's not just interest in technology, this is actually helping people feel better and feel more connected to their healthcare team as they recover from their illnesses. Our providers have 90% satisfaction. They also have enjoyed it. About the 10% who aren't satisfied wish they had more direct control over the remote monitoring program and that we didn't have this centralized resource. And we actually have a vision that once we get enough experience with remote patient monitoring in our clinic, that clinical areas might graduate to having their own locally controlled version of this. But for now, as we're still getting our arms around the nuances, that we want to have that centralized resource, the expertise to understand how best to implement this service. Now, as I alluded to before, I've told you a lot of solutions, and how do you get those implemented into a practice? Well, one of our biggest problems is physicians go to their annual cardiology meeting, and the vendor floor is full of great startup companies who have great ideas, and someone comes back and said, I must use this tool in the practice. And you're like, great, we have 12 of those already, and we can't stand up another independent one-off solution. And then you talk them through, well, what's the solution you need? Because everything comes at a cost. There's technological complexity to putting it in place. I talked about how video is very complex to put in place. We all think that it's pretty easy because we use Skype or FaceTime or whatever on our devices. But when you're interacting with your kids at college, like I do, you forget about the times that the video glitches or there's a little drop in audio because it's low stakes most of the time. But if you're someone who had a biopsy and you missed the word not in front of the word cancer, that's pretty critical. You have to have super high reliability and uptime on the devices, and you have to have a secure connection. FaceTime and Skype are not secure from a HIPAA compliance and medical privacy standpoint, so the solutions have to account for all of that. So you need to figure out which complexity solution makes the most sense for the patient at the right time. The technical complexity is one thing. The technology is ahead of the clinical workflows. So the workflow implementation is another complexity. How do you get a physician or the care team to change the way they're doing business in the 150-year-old model that seems to work pretty well for a lot of patients? How do you get them to change their workflows to adopt these new technologies? And that's the challenge we have. And so this is where I try to get people away from saying, Dr. Ommen, I want video telemedicine for my practice, and start asking them let's step away from the solution first and find out why you want video. What's the problem you're trying to solve? Or conversely, I have them walk through this thought exercise with me. And I said, if you have to get the approval of our CEO for any patient you want to come see you in your office, which patients are you going to stop asking permission for because you know you can take care of them differently? And what would you need to know about a patient who wasn't coming to your office to make sure they were okay? In my field, the standard is after a patient has a heart valve replacement, they would come back and see us at 3 months and then get echocardiograms every year for the rest of their life. Well, guess what? Heart valves don't start to deteriorate until at least 5 years after they're implanted. So that first 5 years of follow-up visits provided no medical value to the care of that patient. What I really need to know is that patient active and doing the things they want to do, and are they having any symptoms? the answers to those two questions, and maybe an echocardiogram about the squeezing function of the heart, tells me the patient's doing okay, and they don't need to come back and see me. I don't need to do more testing for them. I don't need to interrupt their life. So I can follow a heart valve replacement patient for years without forcing them to come back to see me. I didn't even need video for that. I just needed the patient to send me a message in the portal. So each provider has different sets of patients that they might say, yeah, for a hypertension patient, what do I need to know about how they're doing? Their weight, maybe their diet, what their blood pressures are, what their pulse rate is, and you can manage their hypertension remotely. So if you have the team members who are taking care of patients go through this thought exercise, they will identify which patients they can justify coming back. The patient who has new symptoms or whose situation is likely to deteriorate subclinically before a patient can detect it by symptoms, those patients probably need to come back, and you can get that justified. But many of the patients that we bring back can be managed in a more simple way. This is another way I walk providers through that. Is it necessary to touch the patient to understand they're okay? If so, guess what? They need to be in your office. Do you need to observe the patient in real time? If so, then video might be the way to go. And that's particularly important as well in some specialties like mental health specialties. If you're counseling someone through a depression or anxiety spell, you probably don't want to do that by texting, because you want to see the facial expressions as you're having the dialogue. You want to see when they look confused or concerned, and their voice might betray them otherwise. So fully informed communication might involve video from time to time. But there's a number of lower cost, lower touch interventions that we can use to help take care of patients. And we think that this will be the next evolution of care. The last thing I'll mention is that when we take those data that we get from the remote monitoring devices and allow machine learning and artificial intelligence algorithms to work on those, then we can start to automate the reactions to a deviation in care. So if you see a patient who's had chemotherapy and you see that their temperature is going up and that their heart rate is going up and their activity is going down, that might be a sign before the patient's aware that they are getting a fever when all their blood counts are so low, and we can intervene on them automatically and not wait for them to have to get admitted to the hospital for a neutropenic fever. And when we can start to use the data science and the AI technologies to automate that care without requiring a human to process it, use the AI algorithms to escalate care appropriately, that's going to be version 2.0 of this remote patient monitoring, and that's going to be what I like to categorize as the lane drift detection for human health. If I can keep you out of the ditch by giving you a nudge in your steering wheel to keep you on the right path and keep you in your own home, at school, or at work, then that's a success for these types of tools. So with that, I will thank you for giving me the opportunity to speak to you today, and we'll entertain any questions if we have time for that.
First of all, thank you very much for a beautiful presentation. I start with a question, because this is all about people who are coming into the clinic.
Yep.
You also talked about pre-visit and prevention. I think that's a next step to reach all these people before they come.
Yes.
Can you do something with that? Who is responsible for that part?
Yeah, so the prevention, I think, is the neglected child in all this, in a way. And in part, it's very sad. In part, it's because of the reimbursement environment. We get paid for taking care of high-needs sick people and not preventing them from getting there. I think that some of this interactive care plan stuff, if we have modules built into it that talk about healthy activity levels, changing daily habits to keep people healthier, reminding them about medications they need to take. That's beginning to get a more population-based approach, a preventative approach to that. So that will be baked into those things.
But in our country as well, we have to a little bit. We all wanted to do it, but nobody is responsible for doing it. So who's responsible for doing this?
Yeah. So I think that we as healthcare providers should be, and we haven't taken that ownership yet. Yeah.
And my second question is, did you say in a very friendly way, doctors are more slow than patients?
Yeah. There's no doubt about it. The biggest impediment to us putting these in place are providers. because they're so busy, they don't, well, part of the problem is we've gone to them and said, here, try this, and they see it as extra work. Rather than saying, why don't you set aside X amount of your practice time to do remote care, if they do it that way, it doesn't feel like extra work, it feels like the actual work done better. Yeah.
I look around. If there are some questions over here, come to you.
I have a very simple, practical question. How do you organize workflow for instance, video consults for doctors? Do you make slots, or do you have a Mercy Virtual approach that you have monitors? Can you comment on that?
Yeah, that's a great question. We have taken the approach to have mixed slots. So throughout a day, my first visit may be a face-to-face visit with a person. The next slot may be a video visit, and there's a little video camera icon on my physician interface in the EHR. I just click on that, and it launches the software for me to automatically connect to the patient. So we want to integrate it into the daily flow for most of our practices. There may be clinical departments who decide that they're going to have people who are assigned to video or remote care for one day, but most of it we want integrated as a mixed slot model.
One more question is for you.
How do you get older doctors on board for a program like this?
I'll let you know when I figure out how to do that. So we actually, and I was talking to some people last night, so we actually have a problem where about 15 to 20% of the doctors think we're woefully behind where we should be, and the other 80% wonders why we're doing it at all. And so we're stuck right in the middle between those two factions trying to get us to go. The biggest thing, I think, though, is to get early adopters in each clinical area who then serve as your champions within their own clinical area to convert the others. So you can't have a cardiologist do it, convince a general surgeon to be great for his practice. You need to have a general surgeon who's doing it, and then that general surgeon serves as the Pied Piper or champion for that area. I can be the champion in cardiology. We need clinical people in each area who have credibility in that area as early adopters. So it's finding champions in those areas and then growing from there.
My last question is, there's coming a lot of data, and it's coming more and more and more and more. You can use them for the patients, etc. Here, of course, we also have many times discussion, especially from very defensive people, say, about privacy, who is the owner of these data. How do you solve that problem?
No, it's a very important question. I mentioned it before. We believe that the patients own their data, so we think the patients have the right to do what they want. I do think that the concerns about privacy are appropriate, but they aren't unique to healthcare. In fact, for me, my banking data is more private to me than my healthcare data is. You know, I could be ruined if someone gets a hold of my account information or my financial information. That's not going to happen with my healthcare information. There's nothing there that they're going to ruin me over. So we don't have to solve this alone. We can solve this with the other industries that are ahead of us. Yeah.
I'd like to thank you very, very much for all your knowledge you shared with us and all your experience. Wish you a safe travel to Bahrain and a good stay over there. But thanks again very much for being here in the Netherlands.
Thank you very much.
Thank you very much.